Good morning all. Dear students, in this clinical snippet mini lecture, we will be discussing various patterns of sensory loss and their localization in neurology. So it's a vast topic, but what is the learning objective of this mini lecture will be, I will try to emphasize on the various important patterns and just what is their localizing counterpart. Detailed neuroanatomy, neurophysiology is out of scope, we cannot discuss, it will be very long, and believe me, even if whatever we will be discussing here, it is enough in any examination by the voice. You won't be asked things beyond this. You will be fairly confident in answering the various sensory losses, patterns and how to localize them. मामला थोड़ा मुश्किल है, लेकिन अगर धीरे से थोड़ा समझ के, because neurology is a little bit in the whole medicine scenario, neurology is a little bit mathematical, logical, and it has an abstract meaning of everything. It's a deterministic science. If we know the structure and its language, we identify the language and localize the structure. Okay. Saying all this, we will start above downwards. If I go above downwards, let's start with cortex. जहाँ जरूरत पड़ेगा तो आगे भी आ सकता है.
तो आगे भी कर रहा हूँ.
हाँ, don't worry. So we start with cortex. Central sulcus, precentral gyrus, postcentral gyrus, parietal lobe, sensory. We all know about the sensory homunculus, and this is the sensory part of the cortex. So what will be the classical pattern of sensory loss in a parietal lobe disease, be it stroke or anything? The sensory loss pattern will be in the contralateral side. If lesion is here, parietal lobe, on the contralateral side there will be loss of cortical sensations, and what are those? Tactile localization, 2-point discrimination, stereognosis and graphesthesia. These are the classical sensory loss that will be happening in a lesion due to parietal lobe. Remember, in neurological examination or in viva voice, you are usually asked what is the basic nuance or to examine the cortical sensation. And remember, for examining the cortical sensation, the spinothalamic sensation should be intact. जब तक पेन टेम्परेचर सेंसेशन इंटैक्ट है, तब तक जाके हम कॉर्टिकल सेंसेशन टेस्ट करने की कोशिश करेंगे. अगर spinothalamic sensations are already absent, there is no meaning to go for cortical sensations. So lesion number 1, that is the cortical sensations. We come to lesion number 2. After cortex, we come to the internal capsule. Internal capsule. Anterior limb, genu, posterior limb, internal capsule. If the internal capsule is damaged, what will be the sensory loss, pattern of sensory loss? Here, in a capsular lesion, on the contralateral side, from face, including the upper limb, trunk and lower limb, whole one half of the body, there will be loss of pain temperature sensation. Pain and temperature sensation will be lost. This is a classical picture, sensory loss. Especially the face will be involved when there is a lesion in the posterior limb which carries the thalamocortical fibers. So when I say thalamocortical, when we come to thalamus, we'll be discussing the thalamocortical fibers which are passed to the posterior limb, due to which contralateral whole side of the body including face, pain temperature sensation is gone. So this is the internal capsule. So after cortex we have discussed internal capsule and sensory loss. Then we go to thalamus. Thalamus. In a thalamic lesion, same thing. In the contralateral face, body, whole side there will be loss of pain temperature sensation. There will be loss of sensation. Any anesthesia in the contralateral including face. And later on, after some period of time, this anesthesia is usually converted into very severe painful paresthesia. Painful paresthesia, which is known as Jerin-Rouss's thalamic syndrome. The patient will complain that as if it is so much excruciating, burning, pain-like syndrome where as if acid has been poured on one side of the body including face. Severe pain, that is known as Rouss's thalamic syndrome. Jerin-Rouss's thalamic syndrome. This is how the sensory phenomena of thalamus we should remember. So after thalamus we will come to the brainstem. After thalamus we come to brainstem. When I talk of brainstem, midbrain, pons, medulla. Okay? But for this lecture purpose, for the ease, we will be concentrating on the medulla, the basic pattern of sensory loss in medulla, that is the lower brainstem, and middle half of the pons and below. Features will be same. So from mid-pontine level down, especially medulla in its lateral aspect. If there is an injury to the lateral medulla, what will be the classical pattern of sensory loss? This will be the classical pattern of sensory loss in the lateral medulla, which is also known as lateral medullary syndrome of Wallenberg. Here, there will be crossed sensory loss. If this is the site of lesion, there will be loss of pain temperature sensation of ipsilateral face and loss of pain and temperature sensation of the contralateral body. Ipsilateral face, contralateral body, loss of pain and temperature sensation. Why this? For this, we should know that this is pons, this is medulla, these are cervical segments of the spinal cord. The trigeminal nucleus, which supplies the sensory part of the face, trigeminal nucleus is anatomically important because the pain and temperature carrying fibers of the trigeminal nerve in the sensory trigeminal ganglion, it descends down from the pons, up to the cervical 1 or 2 C2 level and crosses to the opposite side to the thalamus, then to the parietal lobe. And this crossed sensory descending trigeminal tract is known as quintothalamic tract. Quintothalamic tract. This is important a little bit neuroanatomically because that is the reason in the ventral medulla, when there is a lesion here in the lateral aspect of the ventral medulla, when I come to high cervical cord, the same thing will be repeated. Here, if there is a lesion in the medulla, The ipsilateral descending trigeminal tract, which is supplying the pain and temperature sensation of the ipsilateral face, is gone, and the contralateral spinothalamic tract will be gone. So this will be the pattern of sensory loss, which is a cross type of sensory loss in lateral medullary syndrome. So cortex, then internal capsule, then thalamus, then brainstem. We are descending down gradually. धीरे धीरे नीचे उतर रहे हैं. Now we come to cord. लंबे सीक्वेंसेस आएंगे. We start with high cervical cord. So if there is a high cervical cord lesion, patient will obviously, in a case of quadriplegia, high cervical cord quadriplegia, पेशेंट को ऑलरेडी क्वाड्रिप्लेजिया हो गया है. मोटर हमको डिस्कस नहीं करना है. पेशेंट क्वाड्रिपेरेटिक है. अब इस क्वाड्रिपेरेटिक पेशेंट में, इन दिस क्वाड्रिप्लेजिक पेशेंट, देयर इज ए सेंसरी लॉस ऑफ द फेस, especially this part, the forehead. The lesion is localized to C1, C2 cervical segments. वो जो quintothalamic tract, that quintothalamic tract we discussed, in that quintothalamic tract, the representation of face is upside down. The representation of face is upside down. That is why in a cord lesion, C1, C2 cord lesion, the part of the quintothalamic tract which is involved, it is representing this upper part of the face, because the face is upside down here. That's why there will be typical loss of pain temperature sensation here, and there can be a pattern of sensory pattern of a intramedullary cord compression. There can be a sensory pattern of intramedullary cord compression. I am not discussing it here. We will write a plus, and along with this presentation there can be a pattern of sensory loss of intramedullary cord compression. We will discuss later. This is high cervical cord. Then another lesion of the cord, which is known as hemisection. Hemisection of the spinal cord. Hemisection of the spinal cord. Adha spinal cord damaged. What will be the pattern of sensory loss? Here the sensory loss will be something like this, which is also known as the Brown-Sequard syndrome. Brown-Sequard syndrome. On the ipsilateral side of damage, there will be loss of position and vibration sense. And on the contralateral side, there will be loss of spinothalamic sensations, pain and temperature, group touch. Along with it, because we are not discussing motor part, still on the ipsilateral side the plantar will be extensor. That means on the ipsilateral side there is a corticospinal tract damage. Why this is happening? Because as we know, the spinothalamic tract is crossing to the opposite side at the spinal cord level. The dorsal column, fasciculus cuneatus, fasciculus gracilis, they are not crossing here. They will cross up in the medulla, in the nucleus, fasciculus nucleus gracilis, forming the medial lemniscus contralateral to the parietal lobe. So whenever there is a lesion at the level of spinal cord, ipsilateral dorsal column sensations will go, and the contralateral side there will be loss of spinothalamic sensation. This is what is Brown-Sequard syndrome. So high cervical cord lesion, then we discussed hemisection of the spinal cord. Now let us go for a total transection of the spinal cord. Total transection of the spinal cord, which is the prototype disease can be a transverse myelitis where the whole cord is transected. What will be the pattern of sensory loss? At the level where the transection has been taken place, below that level, there will be loss of all modalities of sensation. All modalities of sensations are lost. Posterior column, transthalamic tract, all modalities of sensation is lost. At the level of cord compression or the lesion, at the level of lesion, if the radical is compressed, as we know the spinal cord roots are coming out, at the level of lesion, there will be lower motor compression of the radicals. You can get a zone of hyperesthesia, on the trunk. Or if the posterior roots are compressed, you may have a band-like sensation. The patient will say, I am having a band-like sensation, as if something is tightly constricted and fitted band-like, a cushioned band-like. So that is due to a posterior column or a posterior root compression. And if the patient says of the burning pain or hyperesthesia, that can be due to a radicular compression. And below that level, all modalities of sensations are lost as far as sensation and spinal cord is concerned. So high cervical cord, Brown-Sequard syndrome, total transection of the spinal cord. Now we come to intramedullary cord compression. Intramedullary cord compression. This is the central canal. Imagine a pathology which is present here and it is gradually increasing. The lesion is here. What will be the pattern of sensory loss? So here, as we know, this is the spinothalamic tract. I will be drawing the sensory tracts only because this is a sensory lecture. The arrangement of the fibers in the spinothalamic tract, lateral hoe or ventral hoe, it is like this: cervical, thoracic, lumbar, sacral. Cervical, thoracic, lumbar, sacral. And in the dorsal column, it is like this: from outside in, cervical, thoracic, lumbar, sacral. So fasciculus cuneatus, fasciculus gracilis, fiber arrangement from outside within, cervical fibers to sacral. In the spinothalamic tract, inside outward, cervical fibers first, sacral fibers outward fibers. So if there is a pathology here which is extending like this, so there will be early involvement of the cervical fibers, then the thoracic fibers. So if you imagine a diagram here, the sensory disturbance is getting a descending pattern. Somewhere from here, there is a sensory loss which is happening. Cervical, thoracic. And why this is happening? The spinothalamic tract, why it is getting affected early? Because in this diagram I am repeating, the spinothalamic tract from the outside, dorsal outer ganglion is crossing in front of the spinal canal, central canal, and going like this. Either the spinal cord, again it is crossing like this, in front of the central canal, going like this. Lesion is here, it is first engulfing the spinothalamic tract, and it is sparing the posterior column. So in intramedullary cord disease, first there will be a descending pattern of anesthesia. If you look at this diagram, when I say descending, somewhere in the whole body, X, Y, in this whole body, this sensory pattern is a hanging type of sensory loss. It is hanging somewhere on the trunk, in the limbs. So descending anesthesia, sacral fibers are last or may not at all get involved. So there will be sacral sparing, no involvement of sacral sensations lost, no sacral sensation lost. Descending anesthesia, sacral sparing, hanging anesthesia, and lastly, when I say spinothalamic sensations are gone, but posterior column sensations are spared, this is known as dissociative sensory loss. Dissociative sensory loss. So what is dissociative sensory loss? You will be asked in examination. What is dissociative sensory loss? Dissociative sensory loss is a characteristic pattern of intramedullary cord compression where the spinothalamic sensations are lost, but the dorsal column sensations are spared. Other things will come. There will be differential diagnosis of dissociative sensory loss. So this is intracord dissociative sensory loss. This is how the sensory pattern in a case of intramedullary cord compression. After intramedullary cord compression, we go to the next sensory pattern, that is extramedullary cord compression. So extramedullary cord compression. Same diagram, but here a little bit differently. Engineering drawing, don't go by the three-dimensional or extra-dimensional neurology. In an engineering drawing here, we know that extramedullary cord compression, this is the spinal cord, this is the dura, that is the covering, meninges, that is the spinal cord covering, and the vertebral bodies. So here the pathology is somewhere in the vertebral bodies or in the spinal dura, and it is compressing the spinal cord from outward within. Now again mathematics, cervical, thoracic, lumbar, sacral. So here there is early involvement of the sacral fibers. So the sensory loss in an extramedullary, extradural or extramedullary intradural pathology would be early sacral sensory loss. And as if the pathology of sensory loss is in an ascending pattern, contrary to the descending anesthesia with sacral sparing in the intramedullary cord compression. Along with it, you may get signs of transverse myelopathy or a transection of the spinal cord or a hemisection of the spinal cord. Any presentation can be there, but remember, sacral sensation will be lost early along with extensor plantars. Upper motor neuron along with ascending sensory loss, sacral involvement early. It's a spinal cord disease presenting itself as per the extension of the lesion. Either it is a hemisection or cross section, transverse cord section that we have discussed. Just in this, I am concluding that early sacral sensory loss will be occurring in extramedullary extradural cord compression, which is also associated with root pains or vertebral pain. These are associated adjuncts of an extramedullary cord compression. This will be discussed later. Root pain or root sensory loss will be discussed later. So extramedullary cord compression over. So intramedullary, extramedullary. Still we are in cord. We are not able to come out of the cord. So don't get exhausted. Neurology seems to be exhausted, but if you catch hold of the mathematical formulas of neurology, it becomes interesting. Now, some different types of sensory pattern related to different etiologies. So there is the anterior spinal artery and the posterior spinal artery which supplies the spinal cord. If there is a thrombosis in the anterior spinal artery, this part of the cord is infarcted, sparing this. We know that the spinothalamic tract Now it's gone because of anterior spinal artery thrombosis. And the dorsal column has been spared because anterior spinal artery supplies this. So this is known as anterior cord syndrome. Here, I am not going to write things, just revising things. Spinal thalamic tract sensations lost, dorsal column spared. So what is this? Dissociative sensory loss, which we found in the intramedullary cord compression section. Dissociative sensory loss can occur in anterior spinal artery thrombosis or anterior cord syndrome. Okay. In the same way, if there is a posterior spinal artery thrombosis, this part is gone. So here, in a posterior spinal artery thrombosis, dorsal column sensations are gone, spinothalamic sensations are intact. Figure number 1, below a level, spinothalamic sensations are gone, dorsal column sensations intact, anterior spinal artery thrombosis. In the same scenario, below a level, dorsal column sensations are gone, spinothalamic sensations are intact, posterior spinal artery thrombosis. Then coming to some specific etiological diseases that can cause specific type of sensory loss. Not much, but with due respect to tabes dorsalis, which is a neurological condition that follows syphilitic infection. After syphilis, 10 to 15 years later, patient can present with neurological manifestations of late syphilis, which is known as neurological syphilis. They can be neurovascular syphilis, they can be tabes dorsalis, and the third one is known as general paresis of Vincent. Forget about it. We are talking of tabes dorsalis, where there is degeneration of the dorsal columns, tract of gall and burdock, dorsal column, posterior column is classically involved in tabes dorsalis. So, as if it is a posterior cord syndrome, as if it is a differential diagnosis of posterior spinal artery thrombosis, though this will be a gradual pattern. Late posterior spinal artery thrombosis will be acute sensory loss. The simile is equal. So, tabes dorsalis, there will be loss of position, vibration, sensations below a level, along with sensory ataxia, loss of position, vibration, sense, gaya, Romberg's test, positive. So, there will be positive Rombergism with sensory, posterior column sensory loss, position, vibration, gone. So, tabes dorsalis. In this diagram also, let us welcome another disease where the posterior column sensations are also gone, along with the pyramidal tract or corticospinal tract. Degeneration of the pyramidal tract along with dorsal column. Subacute combined degeneration of the spinal cord. Subacute combined degeneration of the spinal cord. Here the difference will be, you will be getting paraparesis with extensor plantars, upper motor neuron signs, UMN signs, spasticity, paraparesis, extensor plantar, but positive Rombergism. Loss of position, loss of vibration. उंगली किधर जा रही है? आंख बंद करके देखिए. ग्रेट टो को हिला रहे, आंख बंद करके. क्लोज योर आईज, होल्ड द ग्रेट टो. Upper down, upper down, upper down. No, I don't know. Down, up, down. Everything is upside down or downside up, whatever. With a positive Rombergism. Subacute combined lesions of spinal cord can be copper myelopathy, hypocupremia and hyperzincemia. So copper myelopathy and SSCD. So these are two specific diseases I wanted to cover. So after that, we come down. Now we are getting steeper through the spinal cord. We are going to come out. Don't get bored now. L1, L2 vertebrae, L3, L4, whatever. Our point of interest is here. As we know, the spinal cord, embryologically speaking, the spinal cord and vertebral columns, phylogenetically, embryologically, they are vertical. Suddenly, spinal cord comes to an end, vertebral column goes down. The spinal cord ends at the upper border of L2. And here is the phylum terminal. So spinal cord is ending at lower border of L1 and upper border of L2. And in the spinal cord, we also know that there are segments T12, L1, L2, L3, L4, L5, S1, 2, 3, 4, sacrococcyx. Oh, this is the area. S2, S3, S4, there is a tumor. There is a pathology here. We know that because this segment and this segment are not corresponding now. The corresponding roots are traversing through their own foramina, going like this. So usually when we come to the L level, the sacrococcygeal roots, the sacral roots are going down like this. So L through S, each is exiting their exiting foramina, but because of the dissociation, there is a root hanging, roots on the both sides are hanging. There is no spinal cord somewhere here. This is the area where there is no spinal cord, only roots dangling down like a tail of a horse. That was the equina, the Cauda equina. And this is the terminal end of spinal cord, which is known as Conus medullaris. So if there is a tumor in the Conus medullaris, we can see that the S3, S4, S5 lower sacral roots are getting compressed, sacral segments are getting compressed. So the classical pattern of sensory loss in this picture will be bilateral sacral sensory loss. Saddle, in a saddle-like pattern. Horse, when we sit on a horse saddle, this area is gone, no sensory. Saddle anesthesia. So saddle anesthesia, lower motor neuron type of clinical presentation in a case of paraplegia. Patient is paraplegic with saddle anesthesia, loss of sacral sensations. Lower motor neuron signs, that is absence of knee, absence of ankle jerk, but plantar is extensor. Is it? Oh yeah, is it? Plantar is extensor because the lesion is still in the spinal cord. The spinal cord will obviously talk in its own language. When there is a spinal cord, there is extensor plantar. But because as the lesion is extending, there are compression of roots also. So radiculopathy is also happening. So we are getting ankle jerk absent, somewhere knee jerk absent here, ankle jerk absent here, whatever. Plantar extensor saddle anesthesia. It's a conus medullaris disease. The disease is the conus medullaris. There will be associated loss of anal reflex, absent loss of sacrococcygeal reflex, anal wink reflex gone, sacrococcygeal reflex gone, saddle anesthesia, lower motor neuron signs, extensor plantar. If the disease is not here, it is in the vertebrae. So there is a pathology involving the vertebrae. Down below the L2 level, where the spinal cord is already ending at the upper border of L2. Now the disease is here somewhere in the lower border of L2. There is no spinal cord at all. Here is a patient presenting with paraplegia. Severe wasting, gluteal wasting, lower limb wasting, absent knee, absent ankle, downgoing or mute planters with some subtle anesthesia, not very geographically symmetrical, but yes, sacral sensory loss, lower motor type of bladder. It is a equina syndrome, which is known as Cauda-equina. This is how Cauda-Conus syndrome will present at its own pattern of sensory loss. With a sigh of relief, exhausted, sigh of relief, we may come out of the spinal cord now. So, after we come out of the spinal cord, we are talking of roots, plexuses, roots, peripheral nerves. So, when I talk of plexuses, say for example, the person is complaining of sensory loss, patchy sensory loss involving the whole arm. When we revise the dermatomal pattern, we see C5 deltoid, C5, C6 outer aspect, C6, C7, C8, T1, and this person is complaining of paresthesias, burning, loss of sensation. C5, C6, C7, whole arm is gone. Whole arm I am having sensory loss, burning pattern. So, mathematically we analyze that this person is having involvement of C5, C6, C7, C8, C1, no cotton touch, no pinprick, nothing. So, probably we are dealing with a plexopathy. Maybe it is a brachial plexopathy. And the same thing occurs in the lower limb, lumbosacral plexopathy. So, plexus means it's a combination of different roots. Fibers are coming through multiple roots. So, multiple, there is no geographic respect to a particular dermatome. It's a flamboyant lesion involving multiple roots, and you know the dermatological distribution, pattern of dermatologic innervations. So, it will be plexopathy. Along with it, there may be fasciculations, wasting, all these things that will localize a plexus type of plexopathy and sensory loss. Coming to roots, individual root. Very important question in examination. You are asked, describe a classical pattern of a root pain. Describe a root pain. So the root pains are severe, short-lived, they live for seconds, lanciating electric shock-like sensations that run in a particular dermatomal distribution. There is a dermatomal respect. A particular dermatomal distribution, short-lived, lanciating shock-like sensory loss or sensory pains through a dermatomal distribution which aggravates with coughing, sneezing, bending, lifting heavy objects, or doing any maneuver that is compressing that particular root. And all these maneuvers, they cause increased intraspinal pressure. Increased intraspinal pressure. So these maneuvers can also aggravate that pain. That is a root pain, and there can be a sensory loss along with those roots. That will be termed as radiculopathy. So if there is a C5C6 radiculopathy, the person C5 shoulder deltoid, C6. That's the outer aspect of the arm. The patient is having sensory loss, paresthesia, burning sensory loss here. So you know that C5, C6 radiculopathy. And this is the classical root pattern. Then come to the peripheral nerve. So don't judge me with these fantastic artistic engineering drawings. Don't judge me. Judge with the mathematical part of the neurological aspect. So root, now we come to the peripheral nerve. So there is simple important examples of the peripheral nerve. Like say for it, median nerve bone, carpal tunnel syndrome. As we know, carpal tunnel syndrome, thumb, carpal tunnel syndrome, the loss of, this is the outer aspect supplied by the median nerve. So sensory loss over the thumb, index finger, middle finger and half of the ring finger. See, mathematically know that it is a distribution of median nerve, so probably the peripheral median nerve has been compressed and this is the area where there is sensory loss, that is carpal tunnel syndrome. Likewise, if there is a tarsal tunnel syndrome, under the flexor retinaculum, the tibial nerve is getting compressed, so the medial plantar nerve, lateral plantar nerve, the calcaneal branch are compressed, so there will be loss of sensation of the sole. Okay, so the tarsal tunnel syndrome, carpal tunnel syndrome. So individual peripheral nerves, we know how the sensory distribution, we can localize that it is a median nerve compression, radial nerve saturday-night paralysis. There will be wave of the first wave space, there is loss of sensation, so radial nerve is compressed. So with wrist drop, so these are the localizing of the peripheral nerves. Now there can be a situation where multiple peripheral nerves are involved in a disease which is known as mononeuropathy, multiplex, इधर से median उड़ गया, इधर से tibial उड़ गया, तो conditions like vasculitis, collagen vascular disease, either the diabetes, they cause attack different peripheral nerves at different junctures. So there will be loss of sensation, individual mononeuritis multiplex. Now the last part, when the peripheral nerves are involved, peripheral neuropathy or polyneuropathy. The list is exhaustive, very important topic. List is exhaustive, you go through the list. We are talking about the neuroanatomy and physiology. Here remember, multiple peripheral nerves, all the peripheral nerves are affected, degenerative conditions, metabolic, toxic, drugs, whatever, ischemic, whatever. So there will be a globe and stalking type of sensory loss. The sensory loss will first affect bilaterally simultaneously from the foot. The sensory loss will gradually go up to the knee. Classical history, burning, tingling, loss of sensation, burning, tingling, it started from the lower limb, simultaneously went up gradually, and when it comes or just covers the knee, tingling starts in the hands, fingers, and it gradually ascends like that. As if stalking and globe. Rather than saying globe and stalking, it gets confused. Sensory loss will always start from the stalking distribution towards the globe. पहले मोजा पहनेंगे फिर ग्लोब पहनेंगे, ठीक है? So this is a characteristic pattern of sensory loss in peripheral neuropathies or polyneuropathies. To end this exhaustive lecture, our motto was just what is the pattern, what the pattern talks of, and what is the localizing sign from cortex till the peripheral nerve. Over. Thank you.